Good morning, everyone, and thank you, SKI, for this opportunity. So we know the basic bearing is a cruciate retaining bearing. Then comes the cruciate condylar stabilized or the CS bearing. Then the ultra-congruent or the deep dish. Then the anterior is stabilized with a more anterior lip. Then a medial is stabilized. So we are increasing the constraint slightly without cutting the box and cam yet. Then the medial pivot, of which Sachin is going to talk on. Then the standard PS, and then the PS plus. So that is the ascending continuum of constraint. CR, CS, UC, AS, MS, MP, PS, and PS plus. All those are bearing options to balance a primary knee arthroplasty in the coronal, sagittal, and the axial plane. But the question we are asking in 2025 is, can we balance the knee in all three planes without cutting for the box and cam? And why this question is pertinent, if we look at the US registry data, you can see the green box, which is the medial pivot, medial congruent, and the yellow one, which is the posterior stabilized. So the PS is going down, and the medial stabilized, the medial pivot, and the CR is increasing. Same trends in the UK registry data, 24, and you can see that the unconstrained fixed, that is the CR, essentially constitutes about 60% of usage in UK. Same trend in Australia as well. You can see that the PS is going down, and the minimally stabilized, that's the CR, and the MP design, the current MP design, is going up. If we look at the Indian registry data, I requested Dr. Pachore for this data, and you can see the row number 4, which is unconstrained fixed. So even in India, almost 40% of our bearings are CR now, or some form of unconstrained without cutting the box and cam. Further going into the Indian registry data, you can see that our women population, the younger women population, is increasing. So ladies in 50s, early 60s are coming, and their BMI is also increasing. So we have younger patients with higher BMI, with less bone density coming for knee replacement. Now why this question becomes important is that when you look at these women, their mediolateral dimensions in the smallest size is anywhere between 52 to 54 millimeters. And when you cut a box, the minimum box is 1.6 centimeters. So you are cutting almost 1/3 of the condyle. And we looked at the box dimensions of all the major implant makes, and you can see that the box dimensions is anywhere between 1.6 to 2 centimeters. And imagine cutting a box in a 50, 52, 54 millimeter ml dimension of femur, almost cutting 1/3 of the condyle in a young patient, 50, 55. So why this is taking cue now is because we want to preserve bone, and we want to preserve the ligament and the whole ligament sleeve so that the next revision becomes easier. Just the way we do in hip, we are trying to do in the knee. We are trying to preserve that box bone and preserve the ligament. And we can do it with condylar stabilized, a CS poly, or an anterior stabilized poly, which will be further elaborated in the talks that follow. So if you really want to look at this classification, I would recommend this paper, which is by Michael Mont's group in Journal of Arthroplasty 25, and he beautifully describes all the bearing options. So this is a classical cruciate retaining option, a kind of a flat design, and this has historically been used. And now we also have a CS design, which is the condylar stabilized. So only the anterior lip is 2 millimeter up, but the dwell point, the point where the femur sits on the tibial poly, remains the same. And now we have bearing options in 1 millimeter sizes. I think that's also a great advantage. So people would like to change it with a medial pivot insert that we'll just hear in the talks that follow. So the important thing is to retain the medial pivot and get the 3 axes of motion, not only the flexion extension, but also the internal rotation, external rotation, and a negative anterior drawer. Getting a negative anterior drawer is crucial. So this is the geometry of the anterior stabilized, of which Guruva is going to talk on. And this is the UC, which is more congruent, more deep dish. And this is the medial stabilized. So medial stabilized is just another poly option to balance the knee, especially a valgus knee, which is slightly lax medially. If you use a medial stabilized poly, it will balance beautifully. So we'll talk more about it in the panel. And finally, this is the medial pivot, of which Sachin is going to talk on, where the femur basically is a single radius design. So we'll talk more on this in the panel discussion. We'll try and fill in the gaps. And I think I'll invite Dr. Rajgopal for his talk on cruciate retaining knee.
Thank you, Anoop. So I've been an ardent admirer of the posterior cruciate ligament forever. And we started off with this concept and I've pretty much stuck to it over the last 4 decades. So we know that knee replacement is a very successful surgery. There's been this perennial argument about retaining or sacrificing. And my bias and my conviction is that retention suffices in most situations. So these are the premises, issues of concern, trust. Can you trust it? Reliable, long-term predictability. Some people say it's more demanding, and the surgeon has to be rather fussy about it. So why do I favor this cruciate retaining? And let's look at the CR rationale: anatomy, kinematics, functional outcomes, flexibility, and deformity corrections. Traditionally, it was believed that PS was the go-to option for severe deformities. What are the fixation options, longevity, and late instability issues? So with retaining the PCL, the exposure is no challenge. And most importantly, because the intact PCL absorbs forces to spare the cement bone interface, we can actually use cementless options. Paradoxical motion is present in both CR and PS, but with the advent of the newer articulations like the medial pivot and the medial congruent, this has reduced. The CR is sagittally stable in mid-flexion during stair climbing, and when you look at long-term data, though they have similar functions, the recent Australian and the American registry has actually alluded to the fact that CR has better survivorship. So the question, what are the indications and contraindications? In my book, the CR knee can be used in pretty much all deformities, and we'll go through a kaleidoscope of these options. The only place CR cannot be used is when the medial collateral ligament is incompetent. This is a 40-degree valgus deformity treated with a CR knee. This was 11-year follow-up X-ray. Gross varus with subluxation, 17 years follow-up. Extra-articular high tibial osteotomy, valgus alignment. Again, CR with stem to get our alignment. Extra-articular deformity, a biplanar sagittal deformity using unconstrained CR option, mini keel option. Ankylosed and arthrodesed knee, this is our 17-year follow-up using a CR knee. Most importantly, we can use this in cementless options today. We can also use the PS with cementless options. This is one of my earliest X-rays. This is a Freeman Samuelson, all poly uncemented. And this is the slide on the right is the TM 12-year follow-up. So how do I modify my surgical? You need to balance your soft tissues, minimal resection. The more the deformity, the less tibia you resect. Get your femoral and tibial rotation right. Always use anterior referencing instruments for femoral preparation, because with severe deformities, you have compensatory overgrowth of the femoral condyle. Ensure good medial stability. It's the medial articulation that makes all the difference. Not more than 1 to 2 millimeter opening on the medial side and 2 to 3 on the lateral side. We looked at radiology using the MG2 and the next-gen CR using the Hollis-Potter classification, and looked at the radiological stress views, lunge views, and also did histopathological examination. And this is at 15 years. You can see the MRI, you can see the PCL really well. We published this in the Acta Orthopaedica in 2014. We also did histomorphic studies 72% had near normal PCL and only 15% was severely degenerated. We published this in the Journal of Orthopaedic Surgery in 2014. These are some of the histology that we found: junctional tissue at this ligament bone interface, which shows viable tissues. This is a patient which we did 14 years ago, had re-explored this at the, because of a periprosthetic fracture, and we noticed the pristine condition of the PCL. So how do I balance? This is very critically important. You need to balance your gaps at 30, 60, and 90 in degrees of flexion, and you can do this either using spacer blocks or trial implants. So the basic principles of PCL retention is that the polo test should be negative, the anteromedial tibia should be congruous under the femoral component, and internal rotation of the tibial component of the tibial construct must be possible with the femoral component in situ. What this really means is you've got a snug medial and slightly loose lateral compartment. So this is the art and science of the PCL retention. Take care not to damage the PCL when resecting the posterior horn of the medial meniscus. Remove all intercondylar osteophytes and the posterior osteophytes, which is critical, and reproduce the natural slope of the tibia. The tibial plate must not lift up in deep flexion. This is reproducing the normal posterior condylar offset, and you can see there's a great deal of variation, and if you don't factor this in, you can actually perforate the posterior tibia. So the advantages are it's present in over 96%, it improves range of movement and efficiency, proprioceptive functions. The 15-year follow-up in CR is better, and present-day conforming design does not lead to increased tibial wear, and this is borne out by data. Long-term results are excellent. So in my experience of almost 35 years and almost 40,000 primary knees, it ticks all the boxes. I'd like to thank you all for your attention.
Sorry, Guru.
Good morning, everyone. Thanks for Parag, the universal #1 in the conference organization. I never seen another guy doing so well. My talk is ultra-congruent and anterior-stabilized inserts in total knee arthroplasty. INSAL uses the total condylar knee in 1974. Since then, there have been improvements in insert design and polythene characteristics. For a long time, there were only two primary insert choices, CR and PS. CR from a New York group from Ranaut and PS from Doug Dennis group. Surgeons would either preserve or sacrifice the PCL with cam post substitution in PS designs. With improvements in polyethylene quality and focus on restoration of native kinematics, condylar stabilized inserts were developed. These do not require box cut, important point, and do not rely on cam post mechanism for PCL substitution. It can be used with or without PCL. Can be used in case of PCL attenuation and recession. Types of condylar stabilized inserts, again, Anoop has shown this paper, very well written paper. Classification system is there. In that, the types of condylar stabilized inserts, anterior stabilized are 23%, ultra-congruent or deep dish 48%, medial stabilized and medial congruent 13%, medial pivot 13%, lateral pivot 30%. In other words, if you take the top two, anterior stabilized coupled with ultra-congruent, almost 70% of the current implants are that size. And again, this was shown by Anoop. This anterior stabilized inserts, this class included all designs with increased anterior stability only, increased poly buildup medially and laterally compared to CR inserts. Increased anterior buildup is the characteristic feature, no posterior buildup. Coming to the ultra-congruent or deep dish, both anterior and posterior lipped and deep dish. It increases the conformity, it increases the anterior and posterior buildup medially and laterally also, and ultra-congruent provides increased stability without relying on the PCL. How do I modify my technique based on the insert? These are questions. No major difference in my approach. With ultra-congruent deep dish inserts, I remove the PCL at the start of the case. In CR cases where I perform PCL recession or pike resting, I tend to use the AS poly, example striker, debut. for additional stability. Most systems are based on measured resection. With the rotating platform, you see insert buccal papas, which I use hundreds and thousands. The instrumentation allows only gap balancing technique. And this is buccal papas. I don't know how many people are using this. This I've been using for the last 18 years. This is the father of debut LCS. And it has got a peg also in the bottom so that there is no spin off from the polyethylene. And excellent short-term and long-term outcomes. I have performed over 9,000 buccal papas TKRs. They are now in fact manufactured in Chennai. And around 4,500 cases over 10 years follow-up. In fact, we are doing a survival study for the buccal papas company. So this is currently doing a 10-year follow-up study now. So indications and contraindications. Outcomes are good irrespective of insert design with a well-balanced knee. Gross deformity, my preference is for PS or ultra-congruent. Mild to moderate deformities, anterior lip stabilized inserts are okay. Inflammatory arthritis, ultra-congruent preferred over PS. The advantages are already enumerated there. How do I manage the PCL? Conventional instrumentation, I adjust tibial slope to match the medial slope, usually 7 degrees. I aim for CR in mild to moderate deformities. I'm a great fan of CR along with Ashok. In fact, most probably we are the two high volume surgeons still married to CR. I inflection gap tight. I release or pie crush the PCL. I use anterior stabilized inserts in most cases. No kinematic conflict because there is no posterior lip. If I sacrifice the PCL for balancing at the end, my preference is to use the ultra congruous. So how do I manage the PCL? Again, UC inserts are designed to be used with the PCL sacrifice. No notch in the posterior insert to accommodate the PCL or bony island. The thick anterior lip on the tibial insert essentially functions as a PCL by preventing the tibia from posterior subluxation, as a riser posterior lip to replicate the function of the ACL. So both ACL, PCL are reconstituted in the design of the poly. Advantages: easier to balance the PCL deficient knee, no requirement of femoral box preparation, easier to implant, highly conforming inserts can improve range of motion. Literature, obviously it is there, and excellent results are there. And outcomes again, survivorship 98.3% compared to 92.3% in CR. All studies evaluating AS designs elected to sacrifice the PCL. And again, outcomes, some of the papers, anti-stabilized, ultra-congruent, excellent results, 18-year survivorship, and excellent results. So conclusions, anterior stabilized and ultra-congruent inserts are an excellent addition to total knee. My feeling is posterior stabilized box and cam mechanisms are no more tenable and no more used or no more needed in the future. And as Anoop said, there is no role for PS, especially in the Indian perspective, where a rheumatoid Indian woman is such a short one. I myself broke medial condyles at least 10 times on the table. So now with this ultra-congruent, this puzzle is solved. So AS and UC inserts can bail you out in difficult cases where the PCL has to be sacrificed. So last one, the 5th and 7th June 2026 in Hyderabad, we got this revision course, and the highlight is there is no delegate fees and all the patients are done free, and I invite all of you to come and join the learning process. June 5th, 6th, 7th, thank you.
I request all to register, not only done free, if the patient is from Pune, he offered the airfare also to the patient to come.
Yeah.
Thank you so much, Guru.
Right.
A big round of applause. For
Yeah, again, as I said, it is under the trust. Any senior consultants here, if you got a deserving patient to be operated, just send the details to me or Adarsh. We will fly them into Hyderabad on our cost, treat them free of cost, and send them back to you. Or if you want to operate on the table by yourself, you can do that. Thank you.
Thank you, Guruva. And may I now invite Dr. Tapasvi for his talk on medial pivot and medial congruent knees.
Thank you very much. And as we've discussed, there are different ways to treat the same problem. So the medial pivot or the medial stabilized is the one category of implants which should not be confused with the medial congruent. I'm going to be discussing the medial pivot. The medial congruent is in between the CR and the medial pivot, and that is not going to be what I'm going to be discussing. So if you want to define a true medial pivot or a medial stabilized, it has to be an asymmetric poly bearing. You need to have a spherical single radius medial femoral component, which is a ball and socket design. And this ball and socket geometry will allow you to have increased sagittal stability, which is very important. Of course, the lateral side is less congruent, and this will permit the lateral femoral condyle to roll and to slide posteriorly with flexion. So the medial side is fixed, the dwell point is fixed on the medial side, and on the lateral side, because of the asymmetric poly, you will have sliding and rolling posteriorly with flexion. What is also important is that your medial pivot or your medial stabilized knee should always demonstrate full congruency on the medial aspect during the entire arc of flexion, right from full extension to well beyond 110, 120 degrees of flexion, and there should be the ability to roll freely on the lateral side. The medial congruent will allow about 2 millimeters of laxity on the medial side, and this is basically designed for those surgeons who want less congruity on the medial side. So the MP or the MS should be differentiated from the MC, and this is one important aspect. So how do I use it in my clinical practice? I resect both the ACL and the PCL. So ACL and PCL both are resected. If I'm not doing a robotic assisted, I would do a measured resection on the femur. You want to balance the medial and the lateral side absolutely properly, and you do not need to cut a box as what Anoop demonstrated in his presentation. So what is important and how should we be balancing it? Well, the medial side should be tight in both flexion and in extension. The lateral side should be tight in extension, and there should be about 2 to 3 millimeters of laxity on the lateral side in flexion is how you want to balance this out. The important aspect with this particular design is that you have very good sagittal stability, and even if you take off the PCL, there is absolutely no risk of any form of residual PCL laxity. You can retain the PCL if you wish to when you're using this insert, but it is not required, and this is the rotation that you should be able to achieve when you have prepared this implant. So how does it fit in with the kinematic philosophy so far? So initially we had the kinematic philosophy of a 4-bar linkage, which is where the multi-radius knee replacements or the multi-radius design was very popular. We then moved on to a philosophy where we believed it was a single rotation axis, which is when we had the single radius designs. But I think what we have settled in on now is that we believe that the kinematic philosophy is a medial pivoting type of a kinematic philosophy, and that's where your medial stabilize or your medial pivot TKR comes into place. Is it important? Well, let's look at this study which was published in JBJS, where they looked at anterior posterior and mid-flexion stability and compared the highest aspect on your primary bearing, which is the PS versus the medial stabilized. And by doing fluoroscopic examination and doing an anterior posterior translation at 45 degrees of flexion, you can see that there is no change with the medial stabilized, whereas with the posterior stabilized, if you are not properly balancing your knee joint, you would find that there is laxity, which is important and critical, and at 90 degrees of flexion, you'll find that it is not too apparent both on the MP and both the PS. So what does that mean? It means that in the mid-flexion range, because of a congruent ball on socket, you will have very good sagittal stability for your MP design, which is extremely useful with the added advantage that you do not need to cut a box. So what about patient satisfaction? Again, let's look at this single center RCT in which simultaneous bilateral TKRs were performed. One side received a medial pivot, the other side received a posterior stabilized. The satisfaction scores on the KSS significantly better, the expectation scores significantly better for the medial pivot, better kinematics for the medial pivot, no difference in the range of motion and complications, and the forgotten joint scores were higher on the medial pivot side. And if you look at all the data, which is a systematic review on all the meta-analysis of all the published data which compared the medial pivot design or the medial stabilized design to another CR or a PS, you will find that in over 4,000 knees, the medial pivot had better proms with better forgotten joint scores with no difference in complication rates. So the advantages are it is predictable, it is reproducible, you can resect the PCL, there is no risk of mid-flexion instability, and this is definitely a durable, versatile bearing choice which has no increased risk of complications with good proms. Thank you.
Request Kanchan Bhattacharya to give the next talk on the posterior stabilized. And that is what the majority of us do, sir.
Good morning, everybody. Can I see a raise of hands for surgeons here who do posterior stabilized knees? And non-stabilized or CR knees? A little less here.
Yeah.
So, who gets what? You know, the debate about CR and PS has been going on for years and years, and we're all slaves of our training. But as opposed to what we are having today, it was different when we started. So I trained in CR, started doing CRs, and then CRs were not available in my city. And there was just one implant available, which was the PS. So I learned how to do PS only because there was no CR available. And carried on doing PS for quite a few years, till the CR started to make a comeback, and then stayed with CR with occasional PS. Why occasional PS and why CR? For a committed PS surgeon, it's a no-brainer that you can do a PS knee to all comers. All kinds of deformities where you want to do a primary knee, you can fit in a good PS knee. And it will take care of almost all the deformities. But over the years, there has been a significant changeover to the CR knees, as Anoop has shown even in our country. When you look at the registry, and you've seen a few registries, and I'm just referring to them, in 2006, the National Registry in Britain showed about 55% PS with about 45% CR, which is now shifted to only about 23%, with about 23% of PS in both fixed and mobile bearings. Scandinavian registry, and in most of Europe, the CR has been in more of use. And considering all the 4 countries, there's a difference. It can range from 2 to 14%, 13% of PS knees. The 2 countries where the PS knees, apart from our country, where it's still being used in large numbers, is the Netherlands and United States. And even there's a small and gentle shift towards CR knees. And why? I think because of the understanding that we have nowadays of the knee, of the designs that have changed, and especially the different kinds of poly that have come about. For people who have been trained in CR knees and having seen the work of Merrill written his publication of several years, you realize that if you know one knee very well, if you know that implant very well, you can do almost all the knees in that category. So when you look at the literature, and even as late as 2019, what are the indications where you would need a PS knee? Where a definite PCL insufficiency, it's still mentioned, posterolateral instability, a significant coronal deformity, inflammatory arthritis, and extensor mechanism deficiencies. When you look at difficult primaries, Mulaji has reported good results with PS knees in coronal deformities more than 20%. But at about the same time, a much larger cohort of patients, Merrill Ritters said he's had very good results with more than 20 degrees of coronal deformity in both varus and valgus with CR knees. When it comes to recurvatum knees, when you look at recurvatum more than 11 degrees, and you have all comers, you've needed CR, PS, and semi-concentrate, all have been reported with comparable results dependent on who has done it and how he has decided to do it. Inflection deformity more than 20 degrees, Bay and then Su in 2016, 2012, seem to believe that PS would be more useful. But everybody who's done CRs knows that 20 degrees in India is kind of par for the course. Surgical technique, my surgical technique is not much different from any others, except I don't use a tourniquet, midline incision, a mid-vastus approach, still use the wide side line and epicondyle axis reference, regardless of whether they use technology or not. Conservative release, and we've all realized that over the years we seem to have released a lot less. We don't know why. Probably we've learned a little bit more, or we have learned that the osteophytes need to be removed more, and that has made it easier for us. Conservative releases. I made a measurement, combination of measured resection and gap management. I take the femur off, distal femur off, then mark the tibia with the insert so that I do not overcut it. I always under-resect the tibia, measure the gap of the extension, then go ahead, do the femoral cutting guide, see my flexion range, see that I don't get it too big, finish the femur, check for extension, and then make a trial and finally do it. So we make sure that every step we do not overcut. We could rather have it tight than loose so that you can go back into it all over again. And in today's context, I think the PS is indicating a committed PS surgeon, gross coronal sagittal deformity where you think you need a little bit of constraint, in a clear case of PCL deficient knees where you do not have the additional implant that you've talked about. And in my case, in occasional cases, in CR knee, when I just cannot prevent the lift-off inflection, then I go and do a PS, a rare occasion, but this does happen. Contraindications that you've seen, small osteoporotic knee where you need a peg, you're going to break it, and I have to. And severe deformities where you would need a more constrained knee. Advantages are it's easier to balance, can be adapted to almost all primaries, usually gives better flexion. Every vendor has one. Long-term results are pretty much the same for CR and PS, and though PS may have a little bit more flexion, the satisfaction index remains the same. Thank you very much.
Thank you, Dr. Kanchan. Please join us here for the panel. Thank you. Yeah, same presentation.
So we will have a panel discussion and in the end some questions from the audience.
Yeah. So 15 minutes we'll discuss with the panel and then 5 minutes for Q&A. Yeah. So let me begin with you, Dr. Rajgopal. How many boxes have you cut in your whole career?
First, qualify your question. Which kind of boxes are you?
Sorry?
He's good at carpentry, so.
Yeah. I mean, box in the femur, sorry.
Only as trial, we did a research paper, Anoop,
Yeah.
and we did about, I think, 500 or 600 of them. But the majority of times we've gone to one of the iterations of the CR/medial congruent/medial pivot.
Right. So, sir, you see a PCL on table. How do you know that that is functionally intact? Anatomically, it may look intact. But what are the measures or what are the signs to tell you that it's functionally intact? Can you tell the house, please?
So, great question. It is a strut of collagen.
Right.
And the paper that I alluded to, where we did a biopsy in, I think, about 120 of them, roughly 77 of them were viable. And we took junctional tissues, and there is a viable vascular structure, even at 14 years. In the balance 22%, like you rightly said, it is a strut, it's a structure. And I think what is critical about doing the CR or retaining the PCL is that you need to get the other factors, not only the PCL, you need to reproduce the posterior condylar offset, the posterior reticular slope, and balance your knee totally through that arc of motion and check it at 30, 45, 60, 90, and 120. You should not have any lift off. And as I also demonstrated, different tibias have different offsets, posterior offsets, and you need to reproduce that. So getting it to about 5-7 degrees
Right,
offset
absolutely.
is critical. If you can do that, and you can take that knee through a range of motion to about 120, 130 on the table with the patella in place, that knee, regardless of the organic structure of the PCL, will do well.
Great, great. So, Guruva, you talked about UC and anterior stabilized insert. There is increasing interest on the offset between the tibia and the femur. Do you believe in reproducing that offset between the tibia and the femur, or you release all the PCLs and let the tibia fall back?
I'm not worried about the PCL at all.
All right.
I ignore the PCL. I just put it there. The ultra-congruous is the best thing that happened to the knee joint. That's what if my knee goes, I want an ultra-congruent knee.
And by your son or son-in-law?
What right knee for my son, left knee for my son-in-law.
Oh, all right.
Guru
Balance
is
is
prepared.
So, Sachin, you're a master arthroscopist, and I'm sure you reconstruct PCLs. Why would you take off the PCL in an MP knee? Why would you do that?
Why do you need to do that? There is no need for you to do that.
That's right.
That is the first thing.
That's right.
Okay, so if you are able to balance the PCL properly, as good as what Dr. Rajgopal does or as Guruva does, you can leave the PCL behind. There is no kinematic conflict.
Right.
One. Second, what happens if you take it out? Nothing happens, nothing changes. You have the same sagittal stability. So if you're doing a medial congruent, which is different from a medial stabilized, you need to keep the PCL and you need to balance it. But if you're doing a medial stabilized, then you can get rid of it. It becomes a very consistent technique without any problems.
Yeah, so point I was trying to bring home was that you can balance the medial pivot knee without taking off the PCL. It's not mandatory to take off the PCL. So Pankaj, what is your philosophy? What do you do in your everyday practice?
So my 90% cases are posterior stabilized. And
90% are posterior stabilized.
Yes.
Okay.
And only 10% patients with varus deformity less than 10 degree, I would do a CR.
Okay. And Adarsh, what about you?
So when we were training, we were doing a lot of PS at one point, but then once robotics came in, we've become more comfortable with balancing with the PCL, and so we've come completely to CR again.
I think, Anoop,
CR again, yes.
yeah, on balance, as I said, the posterior stabilizing usage should become less and less.
Yes,
Should.
absolutely. Absolutely.
Should,
Yeah.
because we have to tell the people, you don't need to cut the box, because especially like a hip, we have to preserve as much bone as possible.
Bone and the ligaments.
And now you got to create alternatives rather than cutting a box and cam.
So, Adarsh, let's see this video, and what would you do in this situation? So here, the medial pivot is not truly intact. If you put a thicker poly, you'll get into a fixed flexion deformity. So the knee is balanced. I've taken out the pins. This is just at the trial stage. The PCL you can see is intact, and there is not much release beyond the midpoint. But the medial pivot is not there. I mean, you can still jog the poly out. So what would be your choice? I'm sure you use this system every day. So what would be your choice? You can see this situation, and there is some loss of medial pivot there. So what would you do in this situation? You would restore to a PS, or you would do something else?
I think it's not too bad, sir. I think it's not coming out completely, so I would actually accept this.
You would accept this?
Yeah, I would accept that.
All right, okay, fine. So, but I would do a CS kind of an insert here. Anyways, coming to you, Kanchan, you said that you are like 100% PS or? 99% CR? Okay, fine. So this will be an apt question for you. So these are some of the CS polys or a deep dish polys, Stryker, Smith, Nephew, Merrill, Zimmer. Any difference between UC polys of these different makes?
See, in my practice, I very, very rarely resort to any UC polys.
All right.
I think normal poly does my job very well. I very rarely need to resort to any of those.
Dr. Rajgopal, any difference between the polys of these different makes? These are UC polys.
So we did a lot of UCs. We've given it up completely because there is a kinematic conflict when you use a ultracongruent. I mean, I'm talking strictly about the Zimmer option. Certainly across the Zimmer portfolio, the usage of UC has gone down considerably.
Why?
Because now we have the medial congruent.
Right.
And then with this option, with Zimmer in particular, you have the choice of retaining or excising the PCL. With some of the others, if you look at the microport ball and socket, they mandate as per their recommendation that the PCL should be taken down. Having said that, we do a lot of medial pivots now, and we retain the cruciate.
Right.
And we have published on this. If you take it down, the range of movement is a little better. If you retain it, the patient satisfaction is a little better, but it's very arbitrary.
No, but I'm sure you were involved with the Zimmer persona insert.
I was actually involved with the UC development.
Yeah,
This
so
was-
I want you to make a good point here, which you always make. Is there something between the back of those polys?
So that little button that you have at the back is really the PCL. That little blob that you see at the back is the PCL. This actually hooks into the back of the femoral component and gives you the sagittal stability. And as you go deeper into flexion, this actually rises up. So this prevents paradoxical motion and it allows for deep flexion.
Yeah, so the point I was trying to make is that all UC polys are not the same. And with every make, there is some difference between the back of the UC poly, and you need to be cognizant of what you're using and where you have to take off the PCL. So as you see, the back of all of these insert is slightly different, and some of them mandate that you take off the PCL. Okay, so Dr. Guruva, do you use MC insert, medial congruent or medial stabilized inserts, or it's always AS?
No, I use medial pivot as not medial stabilized. I use medial pivot as much as the ultra-congruous.
Okay.
Yeah.
And Sachin, do you use MP for all 100% of your cases, or
No,
what's your...
so 40% is medial stabilized or medial pivot, 60% is ultra congruent.
Okay, all right, but not pure CR.
Not pure CR, and the reason I use 60% ultra congruent is the robotic system mandates me to use an ultra congruent. I cannot use a medial pivot for them.
All right, so I think we have 4 minutes left. Let's take the house questions, and all of you. 1 or 2 more, okay.
4 minutes for you and then 5 minutes here.
5, okay, all right, fine. So, Pankaj, any thoughts of the difference between CR, anterior stabilized, and the ultra congruent of this particular make? Do you use this particular make, Smith Nephew? Any experience with that?
No experience with Smith Nephew, and I use only standard CR poly.
Standard CR poly.
Yes.
All right, fine. So, Adarsh, let's take this case situation, and this is a case where you can see that there'll be some play again. I was discussing this. So how much play would you accept with a 90-degree flexion in a multi-radius design? Is this play acceptable to you, or is not acceptable to you? What kind of play would you accept?
I would accept this play actually.
You would accept
I would
this?
accept it, but
Dr. Rajgopal, would you accept that much of play that I just
Because the
showed?
CR is intact, right? And the
Yeah,
PCL is intact.
PCL is intact, yeah.
No, I would not.
You would not? No. So what would you accept? It's absolutely rigid.
I need a snug medial, 1 millimeter at best, 2 to 3 millimeters at that range of flexion.
Yeah, so this is acceptable. Now, please see if this is acceptable.
I would say so.
Yeah, this is acceptable, yeah. So medial, it should be a solid medial ball and socket, and there should be no anterior drawer. Now you can see that my knee is very solid. It's in coronal, sagittal, and axial plane. There is no anterior drawer, and I've changed the poly to anterior stabilized. So that kind of medial snug poly is very important for the patient to go up and down stairs smoothly. Okay, Kanchan, so this case is for you. This is, as you can see, a post-traumatic case, and the PCL is just not there. It's just not there. It's redundant or dysfunctional. So you would do a PS in this, or you would try something else?
Rare cases that I'm going to use ultra congruent.
Okay, ultra congruent. Dr. Rajgopal, for you, medial stabilized or ultra congruent, and why?
So the fact that PCL is not there becomes redundant if you're using a medial congruent or a medial pivot. Increasingly, I am subscribing to the pivot design. So for me, this would be a medial pivot.
This would be a medial pivot, right, okay.
Either medial pivot or ultracongruous. Both work the same.
Both work. So I've used ultracongruent. Sachin, what would be your choice for a post-traumatic case with a redundant insufficient PCL?
Medial pivot.
Medial pivot. Pankaj, PS? Yes. PS, Adarsh? Ultracongruent. So you can see there is increasing use of medial stabilized or medial pivot where the PCL is not intact. So you lose your anterior drawer, so you snug with an artificial medial pivot or a medial stabilized insert. That's the take home for 2025 and beyond, that we should be able to balance our knee in all three planes with either a CR or a medial stabilized / medial pivot and get a negative anterior drawer along with internal rotation of the tibia on the femur. And now let's have the house questions, please.
I have one question, Anoop.
Yes.
What would happen if you used a normal CR here?
You would not get the sagittal balance. You will not get the sagittal balance inflection.
Sir, I am Dr. Anand from Bangalore. My first question to Dr. Sachin, what is his experience with the Indian MPK knee? Is it,
Sorry, I have no experience.
yeah, no experience. And I would like to ask the second question to,
We do a lot of biorats. They are exact replicas of microport. They're as good as microport. Yeah.
okay. The second thing is for all the esteemed panelists, what is your experience with the Indian implants, whether it is Max, Merrill or Biorad, as far as the design, the longevity of the poly, can you give a message to the audience?
We use a lot of Merrill, we use a lot of Biorad, we use Arthroplasty, Buccal Papas I've been using for last, manufactured in Chennai. Till today, I have not found any major structural or conceptual differences. They are exact replica of established foreign companies. They are manufactured as good as any company. We have visited the companies also. Polyethylene is sourced from Germany. And so all of them are as good as any foreign companies. I don't have any hesitation to say that after 18 years of using Buccal Papas, which is manufactured in Chennai.
Parag?
Yeah.
So
Now coming the revision instrumentation also.
just one case scenario for all of you. We'll start with you. So if you don't have, you're going to use an ultracongruent or a medial pivot, three options. A, you will always try your best to retain the PCL. B, you will always remove it. Or C, you don't care.
Always retain. Always
Try your
retain.
best to retain it.
Always retain.
What is your take?
Retain,
Rajgopal
but
sir?
I don't care. It is like mother-in-law, I keep telling.
Means you try to retain, but if it goes, you don't bother.
Yeah, I respect. If it doesn't bother, let's go.
So what would you?
You've already
So
got
no, there is a
married.
point there. Sorry, may I interrupt? So if you want to take the PCL off, take it at the beginning of the surgery, not in the middle of the surgery.
Why?
Because that's going to change your flexion and extension gap also.
Exactly.
And extension gap also.
So, Parag, if I can add
Sorry,
to that.
It's a take-home for the youngsters. The best way is to retain the PCL and put an ultracongruous.
Like as Anoop sir was saying, sir, some of the designs are made for taking out the PCL, like the Buccal Papas. It's an ultracongruent, but you have to take out the PCL in the
Have to
beginning
take out.
because there's no
Depends on
slot in the
design,
back.
But if a design permits both,
Then we can keep it. Yeah, then you would keep it.
The difference, Parag, is in the gait analysis. When you do gait analysis, how much it actually contributes to clinical manifestation is different. When you do retention of the PCL, when you do heel strike, that mid-stance loading is about 20% better if you are retaining your PCL as opposed to excising it. When you excise it, there is a certain greater degree of rollback, so your stride length is that much longer.
Right.
Climbing stairs with retention is better,
Right.
and coming down is better with excising it. That's
Sachin, and
Yeah.
then Pankaj.
Sorry?
Your take on this issue, PCL.
Yeah, so I think I am not really too bothered about the PCL.
So you don't
and
care, you keep it or leave it.
Absolutely, but as has been rightly mentioned, the decision to release or keep it has to happen, before you start. As soon as you open it, it becomes a part of your release, and that's when you make your decision.
Pankaj.
Retain.
Can I ask?
Yes, please.
Ashok,
Ashit, yeah. That's the last question, I'm
Okay,
afraid. Yeah.
so
Yeah, afterwards.
Yeah, so we have this discussion on the bearings and the polys. But what we really need to know also is the design of the implant, that's a mobile bearing and the fixed bearing. Now, there are only two mobile bearings that we have. One is a buccal papas and one is RP mobile. Now, do you think, the entire panel, that whether this mobile bearing is the important thing or the poly? The design between the femur and the poly, that is important thing for the longevity of all these implants.
Guruva, maybe you can take that.
Yeah, again, since my learning or the literature suggests if it is ultra congruous, you should have at least a rotational play, mobile bearing, rather than a fixed bearing. That is the fundamentals I brought up with. So I'm very comfortable with mobile bearings in ultra congruous.
Right. So,
Can I ask one question? I would like to know from the panel is that, Anoop, we saw your videos that you were testing the sagittal stability with the patella everted. So, intraoperatively,
Yeah, no.
would you want to make an estimation of the stability with the patella reduced or everted, one? And if, like, that's what I follow, if I want to put in an ultra congruent, I do my trial and my testing with a flat CR, be happy, and then put an ultra congruent. So, two questions.
Patella close is the most scientific way of seeing the stability. Even polo test, you should put patella back into place and do that. And coming to the flat CR and ultra congruous, it makes your life simple. Rather than trying a ultra congruous insert and pulling it and pushing it in.
Even if I'm doing, even if I have to do a medial pivot, I would put a flat liner, ensure that my stability and my balance is perfect, and then put it in.
Okay. Yeah, thank you very much. Thank you, panel. Thank you, House, for your questions. Thank you very much.
Please line up for a photo.
Thank you, Dr. Jhurani and all the panelists for that enriching session. Now we'll take a quick ARS before proceeding to the next session, which will focus primarily a couple of questions on the bearing surfaces, and then we'll take a few general questions about your surgical workflow.
Yeah, so please be ready with your ARS. We have to finish this in 4 to 5 minutes. Sahil, we can start, and I would request the panelists to come down and vote as well.
So the first question is, my preferred bearing choice for primary TKR in a varus deformity is option number 1, CR, option number 2, PS, option number 3, ultra congruent, option number 4, MC or medial pivot. Oh, so tiebreaker between CR and PS. Ultra congruent is third with 20%, and medial congruent or medial pivot is the lowest at 12%. So CR and PS still seems to be the top choice. The next question is, my preferred bearing choice for a primary TKR in a valgus deformity is option number 1, CR, option number 2, PS, option number 3, UC, option number 4, MC or medial pivot. So in a varus we had equal CR and PS, but in a valgus knee, 60% are preferring to go for a PS design. So that's interesting to know. The next question is...
Just one comment by...
Sahil, just to your previous question, medial pivot is a game changer in valgus knees particularly, because it snugs up your medial, which is really where the pathology is. You know, you got this instability issue. So for valgus knees, our go-to is the medial pivot.
Oh, thank you, sir. The next question is, when I choose an implant brand for TKR, what is my most important criterion? Option number 1, clinical evidence. Option number 2, cost. Option number 3, brand reputation. Option number 4, availability. And option number 5, other factors like the robotic system available in my hospital or my hospital policy, etc. So 38% are actually looking at the clinical evidence when choosing their implant brand. The second was 19% who are going as per the availability. Now, what is your preferred patella management strategy in a primary TKR? 1, always resurface. Option number 2, never resurface. And option number 3, selective resurfacing. So 41%, again a second tiebreaker between never resurfacing and selective resurfacing. But interesting to know that only 18% are always resurfacing their patella.
If the serum fructosamine is higher than 292, that had a significantly higher risk of postoperative deep infection. Do HbA1c, if it in trend, is a far more reliable index than a decreasing trend of HbA1c. This is not a very known fact, but I would urge it is another different animal, dependent. In these cases, Savya, what do you do? What is your take?
We try to convert them into IV prednisolone.
Yes, because sometimes some spine surgeons actually give a short dose of IV steroid just before surgery or less, because we know steroids given in high doses have series of complications which can happen. The immunity is compromised. These are all.
It is based on this module that we had. So I'd request all of you to take hold of your ARS pads as we start with the first question. For my patients prior to TKR, labs like D3, serum proteins, that serum albumin, etc., my protocol is option number 1. I routinely do it and check the values myself. Option number 2, I routinely do it as a part of my pre-op panel, but I admit I don't really check these values. Option number 3, I was not routinely doing it, but after this panel discussion I will start. And option number 4, I don't really care as long as the patient is deemed fit by my anesthetist and physician. So Parag sir, you'll be glad to know that your panel discussion was successful because 47% admit that they were not doing it routinely, but after this panel discussion, they will start doing it. So we are moving away from being true orthopedic surgeons to being more doctors. The next question is, do you use a tourniquet for your primary TKR? Option number 1, yes, full duration. Option number 2, never. Option number 3, only during cementing. So 88% are still using a tourniquet throughout the duration of their TKR, and only 8% use it during cementing, and 4% never use a tourniquet.
So anybody wants to comment on never use a tourniquet? Who made the no answer? They were 4%. So because people, I started not using it, but within 6 months I started moving to use it. Again, I tried to use it only while cementing. That also I moved away. TKRs in our hospital take typically 20-25 minutes. We are done, so I use it for all through. Any, Jhurani, you don't use it. I don't use it. Any regrets?
No, none at all. I don't have a tourniquet in my OT actually.
So is that the reason you don't use it, or is that the reason you don't use it?
Ski will gift you one.
I've given it to my arthroscopic.
Okay, yeah, fair enough, but that's what I thought. There was a wave when people stopped using tourniquets, but very quickly I moved back to start. Because it makes just life, makes it easy.
So, Jhurani sir, both of us and Parag sir are Ranawat fellows, and the recent Ranawat award paper actually showed no difference in patients who had a tourniquet and didn't have a tourniquet in the recovery post TKR at day 1, 3, 5, 2 weeks, and 1 month. So, we can debate that. True, that is of course.
surgery.
A very senior surgeon had told me many years back, and even I think I've read it in one of the old textbooks, that tourniquet has no advantage to the patient. It is only an advantage to the surgeon.
Jhurani sir, rebuttal.
Just as an experiment, put a tourniquet in your own leg for 60 minutes.
I agree. Yeah.
And then see what happens in the distal part of the leg.
Yeah, just on a lighter note, now this BFR, is becoming a very popular tool in physiotherapists. Blood restriction therapy, BRT as it is called. So they actually stop the blood supply for 15-20 minutes, and then they exercise the knee joint and then ankle joint, and they are showing some excellent results. So this is that blood flow restriction therapy, BFRT. You can just Google it. Okay,
So
let's
we'll
move
continue
on.
that debate in the coffee break. The next question is, do you have a BMI cutoff for your primary TKR? Option number 1, 35. Option number 2, 40. Option number 3, 45. Option number 4, no cutoff. So 47% is the majority that feel a BMI cutoff of 40 is applicable in their practice. Guruvareddy sir, just a quick question for you. You said you refer a lot of patients for bariatric surgery. There are reports which say that bariatric surgery coupled with TKR, some of these patients do tend to develop ligamentous laxity later on. Have you seen that in your practice?
Of course, I cannot comment with 100 patients like that. Probably I must have done 5 or 6 post-bariatric. I never had any problem. And contrary to Parag's opinion, these people after bariatric, they look more agile and they're more happy, not depressed. But of course, they are very lax, and some plastic surgeon has to tidy up their skin and all that. But knees, they are done well.
Rajgopal sir, any rebuttal from your side?
I never argue with Gurva, particularly in Hyderabad. I need to get to the airport and board my flight. But on a more serious note, like I said, I do not have a cutoff because these patients are actually quite unfortunate, So if you get the right patient, you counsel them well, explain the likely complications, they actually do very, very well. And like I said, the majority of our patients, we've had our share of skin necrosis and fat necrosis and all of that stuff. Always use a stem. Always use a tourniquet in these. So you need extra large tourniquets for some of these people. Have good retraction, good visibility. And these patients actually do very well. And these are patients where I personally believe you do not want a kinematic type alignment. These are patients where a neutral alignment, whatever neutral means to you, these patients will do well. They will lose weight post-operatively.
Thank you, sir. The next question is, what is your drug of choice for DVT prophylaxis after primary TKR? Option number 1, aspirin. Option number 2, low molecular weight heparin. Option number 3, direct oral anticoagulants. And option number 4, others. So 42% are using aspirin. 38% are actually continuing low molecular weight heparin, and 16% prefer direct oral anticoagulants.
So retrospectively, we could have given another option. So how many of you actually start with low molecular weight heparin and move to ecosprin? A show of hands. I think the vast majority of us do that, so we didn't give that as an option, but probably that's the way. That's why some people have gone to the B option, which is 38%.
Okay, so we'll try and cover that again in the next ARS. In a patient who is medically fit for bilateral TKR, I prefer option number 1, simultaneous same day. Option number 2, staggered 3 to 5 days apart.
Same admission.
Option number 3, staged 6 weeks or more apart.
You discharge the patient and call them back. That is stage the C.
So 62% are preferring simultaneous, that is same day, bilateral TKRs. Then,
Sahil, I think in this question we should also add the age criteria over here. Because, you know, some of us, I certainly have this, even in a fit patient over the age of 75, with relatively, with no comorbidities, I will not do a simultaneous bilateral. I would do it staggered. Yeah.
fair point, sir. The next question is, my antibiotic protocol for primary TKR is option number 1, 3 doses only, that's 1 pre-op and 2 post-op within 24 hours. Option number 2, 3 days. Option number 3, 5 days. Option number 4, 5 days plus oral. So 34% are using only 3 doses, but 29% are still continuing it for 3 days, which is roughly the duration of the stay in the hospital. 15% are continuing it for 5 days, but 22% are even extending it to oral antibiotics post-discharge. Dr. Thakkar, if you can just tell us, I know the ARCUS recommendation is 3 doses only, and you're discharging patients often the same day. And I believe Dr. Michael Menegini is also doing a study on 1 dose. So can you just tell us what is your protocol in the US for these patients?
Yeah, so typically if we are discharging them the same day, they'll get 1 dose pre-op, they'll get 2 doses post-op in the recovery unit, and then they go home. The only time we do the 5 days or 5+ days is the extended oral antibiotics, which is gaining a lot of traction for high-risk patients, diabetic patients. But the problem is that nobody's following a set protocol set by Michael Menegini. Everybody is giving whatever they feel like. So antibiotic stewardship for that is very important.
As Neeraj was telling, the tourniquet is for the surgeon than for the patient. Same thing, except 3 doses, the rest of things for the surgeon, not for the patient. We all been doing, all of us are doing with 3 doses with equal efficacy and same infection rates.
Yeah. So if we can just have a show of hands, how many of you are using only cefuroxime? Okay, and how many are using cefuroxime plus some other antibiotic? Okay, still about. Fair enough.
Sahil, again, sorry to be bombarding you with ICM guidelines. We just published one of the ICM questions. Cefazolin is the drug of choice for 3 doses as per the 2025 ICM guidelines.
Yes, sir. So in India, we're using cefuroxime, sir, because we don't have cefazolin. So.
We do get cefazolin. But
Cefazolin
because they are
is
not
available.
easily available, I think
availability,
people,
is the
availability
issue.
is an issue, and they are promoting the second generation. Cefazolin is the first generation, which costs nothing.
Yeah. So that is the recommendation of 3 dose, 1
Cefazolin,
pre,
yes, sir.
peri, and 1
Within 24 hours. The next question is, do you routinely collect any functional scores post-TKR? Option number 1, yes, patient-reported outcome measures. Option number 2, yes, surgeon recorded. Option number 3, no formal documentation. Option number 4, I would like to collect routinely, but time and manpower constraints are there in my practice. Option number 5, only if I want to do a study. So 46% would like to collect it routinely, but because of time and manpower constraints are not able to do so. So that's an interesting point to note. Shyam sir, anything from Ortho AI that you can help them with for this?
So Ashok, please, your comments. How can we make sure that the time constraints are less?
Like I was discussing with somebody yesterday, it's never a lack of time, it's lack of priority. You need to prioritize it. That's it.
Ashok, you rightly said that. I was shy of this one, and the last 5 years we published more than 100 papers. Just because of your change of priority. I'm spending more time in the research than with my wife. That's it.
The last question, do you routinely perform digital templating for primary TKR? Option number 1, yes. Option number 2, no. Option number 3, only in complex cases. So 74% are not performing any templating for the TKR cases.